I don't look stressed at all because I have former fellows in the audience that I've already planted. My name is Shirin Towfigh. I'm going to take the other argument. I'm an adult surgeon. I do treat adolescents at times when our pediatric colleagues are unable to take care of them. These are my disclosures. So I felt like I was the only general surgeon that agreed to take on this site. I'm kind of free soloing it, but you know, the courage of doing this allows me to kind of provide you with my take on the fact that conflict is good. It's good that the two of us have different viewpoints. It encourages debate and thinking outside the box. And in the words of our great IHC leader, Dr. Brian Jacob, I am here for the sake of debate. So what is the problem? One is we have an inguinal hernia, it's in an adolescent, and we'll provide two different treatment options. The pediatric option, which is a laparoscopic high ligation, and the adult option, which is a mesh-based hernia repair. But not all adolescents are the same. There are three stages of adolescence: the early 10 to 13-year-olds, the mid 14 to 17-year-olds, where they're continuing with their growth spurt and puberty, whereas most females are finishing their physical changes, and the late 18 to 21-year-old adults who are mostly done with their physical growth and have reached their complete adult height. So I would submit that it's pretty logical that anyone under 13 will be treated by a pediatric surgeon, and they would undergo tissue-based repair. I don't believe that there's any debate about that. In fact, most hospitals have a policy under age 13. The patients that come to the emergency room typically are taken care of by pediatric surgeons, and it's the over 13 population that mix in with the adult surgeons. So what's the right answer? And who's right in this debate? Is it the general surgeon or the pediatric surgeon? Let's talk about the pediatric viewpoint. So we are told over and over again that adolescent inguinal hernias are due to incomplete closure of the processus vaginalis. And it's not an inguinal floor defect. Do we really know that? Who's actually looked at that? We've looked at tissues and compared the tissues, but in adolescents, do we really know that that open hole is a hole in the muscular, as a muscular defect, or a opening that by chance the peritoneum tends to go in there? We don't really know the answer to that. What we do know is that the processus vaginalis closes in about 60% of children by age 2, and then over the span of many years, the rest of them close. And among the hernias that are seen in children, over 95% are indirect inguinal hernias, but don't forget, up to 5% will be direct hernias, and just under 1% will be femoral hernias, and that is part of the population of hernia patients that surgeons will be addressing. Now, the pediatric argument is, these are not really inguinal hernias. This is a patent processus vaginalis. That door really isn't open. I accidentally left a towel in there to keep it open. My argument is you have a door that has a spring to it to naturally close right now. If that door is open and you happen to put a towel in there, fine. But if you remove the towel without that spring, that door will remain open. So what is a patent processus vaginalis? How many would consider this a patent processus vaginalis? How many would consider this an inguinal hernia? What about this one? How many call this a patent processus vaginalis? And how many inguinal hernia? Last slide to discuss this. How many would consider this a patent processus vaginalis? How many would consider this an inguinal hernia? Almost everyone. For the record, all three of these are called patent processus vaginalis in pediatric literature, and therefore would be treated by high ligation. So to classify this further, a set of surgeons took the Nyhus hernia classification that's intended for adults and transformed it to recommendations for the pediatric population. The type 1 is a typical indirect inguinal hernia with a normal ring, and the recommendation by pediatric surgeons is sac ligation. In this paper, they also called the type 2 Nyhus, which is a dilated ring, something that would require tissue repair, but mostly just closure of the canal. And then they jumped over to a type 3B, which is either a direct hernia or a combination large indirect pantaloon hernia, and they recommend formal tissue repair. So sac ligation really is intended for a patient with a normal ring. So the question is, what is a normal ring? If you ask the pediatric surgeon, they may look at this as the patent processus vaginalis. I look at this in the article, I was stunned. This to me is an inguinal hernia and should be treated as such. So what's a kid and what's an adult? This is a debate that probably will, especially with the millennials, probably will never get addressed. But a pediatric surgeon may consider this a child or a kid and treat them as such. I would consider this an adult and treat them as I would most adult patients. But I want to be a little bit more objective, so I went to my group of hernia surgeons. If any of you are on Facebook, I highly recommend the International Hernia Collaboration. We're over 7,000 surgeons, most of them general surgeons. And I asked a simple question. 16-year-old male, BMI 31, bilateral inguinal hernias, mesh or no mesh? 113 said mesh, 4 plus 3, 7 said no mesh. I think I won my argument right there. They also came up with some interesting data. A BMI 31 or 32 may not be obese in the pediatric population. For those of you that are following March Madness, Duke Zion Williamson, he's 6'7", 285 pounds, 18 years old. His BMI is 32. But those of you that are in Michigan State, it doesn't really matter because he lost, and therefore we don't really have to fix his hernia. All right, so let's think of some history. This has been done before. High ligation has been done before in adults. It doesn't work. Since 1969, high ligation and excision of the sac has been abandoned in the repair of all indirect inguinal hernias in adults. Dr. Lichtenstein. And in fact, we know that high ligation is not the one-all for all inguinal hernias. One famous surgeon said the decision to perform high ligation versus mesh repair depends on the patient's age, size, and findings at groin exploration. It doesn't say anything about direct versus femoral versus indirect. And who is this surgeon? Oh, Dr. Ponsky. So what's wrong with mesh? First of all, we believe that mesh, we know that mesh does not stretch, and so growth may interfere with it locally. There are some concerns with fertility and scarring of the vas by mesh, never been proven, but it's theoretical. And I do believe we should not do harm. So mesh may be over-treatment of hernias, not only in adolescents, but also in adults. So when would it be appropriate to use mesh? We know that there's about a 3% recurrence rate, and one of those recurrence rate causes, besides patient factors and technical factors, is a large internal ring. There's also the at-risk patient population, those with collagen disorders, probably not the right choice for high ligation. Direct hernias has been established, not appropriate for high ligation. Large indirect inguinal hernias proven to be higher risk for recurrence, not appropriate for high ligation, or any acquired hernias. And then lastly, let's not forget the concept of the hidden hernia. This is part of my passion because this is missed all the time and patients are left with chronic pain. Does anyone see a hernia here? I would submit that there's potentially fat on the other side of this peritoneum plugging the inguinal canal. Just because there's no peritoneum going into the hernia defect does not mean that there isn't content that's causing the person's pain. And you will not know that until you take down the peritoneum and actually look at the muscle itself. And lastly, and this is actually a patient, he's a 16-year-old from my office about 2 weeks ago. And this is what the MRI looks like. He's got content in the inguinal canal, severe pain, bulging on examination, and has an inguinal hernia. So to summarize, this data has already been looked at. But my final comment is on mesh. Not all mesh is the same. We're having more and more varieties of mesh options, including biologic absorbable, synthetic absorbable, and partially absorbable hybrid meshes that don't have the inflammatory component that we see with much of our synthetic mesh. And so the options for mesh are there in patients that need it, and we should tailor our approach in our adolescent patients. Thank you.